Hey.
Hi. Good, thanks. Good.
Hi.
How are you?
Hi, how are you?
Good.
Good. Always late. Yeah, I did call him since we left 10 minutes ago, but he wasn't really lost.
Oh,
Okay. Well, it's crowded in here. Did you get my? I forwarded you some information to CMA.
Yeah, I've got all that done.
Okay.
Yeah. With the email now, there's only one box.
Yeah.
I'm gonna go through it, but
Yeah,
I
you
also
can't
want
together. You have to respect.
Pretty
much have to respect right
If
around.
you can just color, and it says area under assistant, the ones you want me to do, put that in, so that I know which ones you want help with.
Show me.
Yeah, well,
All right.
What do you mean, all right? Dr. Onrot, you better get a seat because it's going to be packed in here. I'm telling you.
Okay, they actually have connectors for Macs, eh?
They do. Yep.
I didn't even
And
know
wait. Don't do that. First, set everything else up because for some
Okay.
reason it doesn't like
that.
it.
Okay.
Okay, then looks like this is all. The speaker is ready to go, anyways.
I have connectors.
Okay, so that's good. So then what we need is
It's 100%
this
sure.
one.
My voice is gone. It's been a stress for the last. I haven't had a voice for 2 months.
Okay.
There's going to be so many people here. You have to speak into
Oh, bullshit. I never have to speak into a microphone.
Misha, you're going to have to speak into a microphone. Can you hear him? Exactly. You haven't heard a word he said, right? See?
Where's the plug?
It'll probably be over.
Oh, the hyper. Oh, but there's no food today. No, there is.
Oh, there's just.
There's always food.
Oh, do you usually set people up, or does?
No, there's somebody that usually comes to help. Well, that's okay.
Yeah, I would have been able to figure that out as long as.
It's more the.
I do have these.
So now do you have your presentation though? Like, let's load it up because it's whether it'll appear on there that
Yeah.
gives us trouble.
Well,
Yeah, but first get it on your laptop.
I didn't turn off my. Guess I did.
There he is.
Yeah, we're just getting ready for you. Okay, great. And we're going to plug this one in here. Do you have an adapter by any chance, or I'll go get one for you?
Yes, I do.
You do?
have all
Okay.
kinds of adapters, but
VGA to your.
I have one.
What do you have here?
no, I have, but
Mini DVI.
somewhere.
All right.
Oh, I don't have
Great.
the one. Oh, maybe you do.
Excellent. Yeah. Why doesn't this work by itself? This thing. It's that one's intermittent. It has. It's like the projector. It's like the projector.
Yeah, the
You know what it is?
I find it works a lot of the time, but it doesn't work sometimes. So I don't know
When
why.
I wanted one for my Mac, even one of these, I felt
Oh,
like
yeah.
I only had to go with the Mac version.
Oh,
Like
yeah.
there's none of the other generic stuff worked.
Yeah.
So maybe
Yeah.
that's why it doesn't like it sometimes.
Yeah,
I'm sure that's
it's.
just
I think it's to do with the
forever.
system,
Okay.
but it's like, for instance, I mean, it's a long story, but this HDMI, it only carries a video, it doesn't carry audio, which it normally carries audio. But because in this system, because of the copyright issues with playing movies, they don't allow it to have sound. It's just one of the picky things about these sort of setups. Is this, in a system, they'll cut that off, right? Because they don't want you to be. Isn't that just bizarre? Oh, okay. Anyway. And do you have any? This has come undone, eh?
We're still, who should be here is Lee, because he's got to do his own projecting microscoping and stuff.
Yeah, I see it there. I see something's happening.
I know.
The signal is there. There we go. Okay, so that's up. And did you have any audio?
No.
No. Okay, good. Yeah, makes it simpler. Okay, so we don't need that guy. There we go. And there is also a, if you want to use the lapel mic here, there's a lapel microphone. However, you don't have to use this if you don't want to, but it is here. and this mic's on as well. Okay.
There was no one there, so I'll go back. Yeah.
So it screwed up my desktop. I can't see a thing now. Oh, there it is.
Yeah, that's fine. I think it is.
When it plugs into the system, it may make some changes in the resolution, but there you go. Let me just do a quick check on this.
Oh, I just texted you.
Oh,
Okay, so how are you going to project your slides?
on US on the computer.
Oh, we have another.
Okay, and you've got. Okay, do you want to use it on this one?
Yeah, sure.
So just plug in right there, and then I'll show you how to switch between the two.
Where's the advanced thing?
You just advance with the arrows
Okay,
on here.
I know how to do that.
Yeah. Okay.
I can actually.
I suppose if you.
I can actually do it from here.
Well, that's what I was gonna say. If you have your own remote, you can. Yeah.
But no, I haven't practiced that yet.
Good. Excellent. And then you just play it off there.
Well, it'll be my last one.
And great. So now, when you want to switch to that computer, because we're using two different computers.
Yes.
This blue area is just basically representing that screen is using the VGA cable right now, which is this one, and then you're going to be using the Lectern PC. So there's the button. So all you have to do to switch is just hit that button there, and that now yours will be up. There it is behind you.
Okay.
So, okay. So I'll go back to him because I assume you're going first. Okay.
Yes.
There you go. And microphone is here, but also this is on, ready to go. If you want to use this lapel clip-on as well. Okay. This is better if you're going to move a little bit. This one you kind of have to stand right.
Yeah.
Next. Okay. It's up to you.
And standing like this far away is good. Yeah.
Yeah.
Oh, okay.
Yeah, 2 to 3 feet.
Yeah.
Okay. Thanks. Yeah.
That will go away 1 second.
Help yourself, Dan.
It's there. It's there. I can't see them.
We actually bought them. Yeah. This is none of this is used. How come?
Well, it's only new. We'll start then. It's only new. Used to be Grand Rapids. Used to be everybody came.
Or is it the zipper?
Oh, There's lunch. All these things. Oh yeah. Late finish.
Oh, thank you so much. It is. Yeah, exactly.
Yeah, we'll get you 3 trips. The initial one, then the one in March. Good. She slides because you had all those. Right, so double click. Double click.
I don't know. I'm on call with him.
Oh.
He's talented.
I was on CTU with the what was the story of how he ended up at St. Paul's Hospital.
How you what?
How he ended up working at St. Paul's Hospital.
Oh. How did he work?
Apparently he was like trying to get a job. They didn't have a job for him, so he just decided to drive to Vancouver.
What?
Yeah, like, yeah, like
Literally?
without a job, like he just drove.
Who's this? Who's Onrot? Oh. Interesting. That's the story?
Yeah, and then he just interviewed and started working here. With no previous ties.
That's the story, right?
Yeah.
That's who I am. No home?
I think so.
Interesting.
Well, Monday.
Yeah, it's all good.
What is that?
Yeah, I have done talks with my iPhone. Oh yeah, so technological.
Good morning, everybody. Welcome to Grand Rounds. It's a real pleasure today to introduce a person speaking who everybody knows here as Jake. Dr. Onrot's a senior internist who's been practicing primarily, I guess, almost exclusively at St. Paul's since the start of his career. And I think today we're going to be given the opportunity to see how Dr. Onrot thinks, how he assesses problems, how he has intuitiveness, and how he has a stick-to-itness to solve the problem. So you can see that the title of the talk, Dr. Onrot has a couple of colleagues helping him today, and he'll introduce them. Dr. Onrot.
Thanks, Barry. For those of you that go back even 20 or 30 years, you'll remember the New England Journal CPCs, which was a discussion where the case was presented to someone who didn't know the case, who would discuss the case, make their diagnoses, and then they'd throw it over to the pathologist who would tell them if they were right or wrong. And then they would ask then they would report what the medical students came up with when they heard the case. Over the last 20 years or so, the New England Journal has evolved to not cold casing the discussants, but getting expert discussants that pretty much know the diagnosis. So this is more like new school clinical pathological conference, but it was a hallmark of Grand Rounds, and I must have done 20 of these in my first 20 years of practice, and this was pretty much all we did, was case-based, case-centered learning. So today we're going to talk about a 45-year-old man who presented to Mount St. Joe's with Anasarca, renal failure, and lymphadenopathy, and no disclosures. Hopefully we'll see how we come to diagnoses in complex patients. I want to talk about case-based point of care learning, talk about how important it is to get cross-specialty collaboration, get help, and you're going to hear about an old disease with a new twist and a new disease with an old twist. And I'm going to try and show you that there's still a value for old school audience participation, large group interactions. So, Mr. SH was a 45-year-old male who was well until December 2017 when he began to get constitutional symptoms. And then he was followed by swelling of his belly, and he noted some left groin nodes. And what brought him to hospital was an acute onset of some left lower quadrant abdominal discomfort. And of course, he had worsened, his ankle edema and belly swelling had worsened, and he was a little dyspneic on presentation. His history reveals that he had a dental infection treated in December. He's worker, monogamous, heterosexual, occasionally dabbled in recreational drugs, was a smoker, had no exposures, and actually had a positive family history in his mom for lung cancer. So a smoker with a family history of lung cancer should always set off alarm bells. At Mount St. Joe, he had massive ascites, massive peripheral edema, looked chronically ill. Vitals were unremarkable except for the rest rate. He had the findings of pleural effusions, sacral edema, and he had a few diffuse peripheral lymph nodes. He had no stigmata of endocarditis, no skin lesions, no tender joints. So I want to highlight a few of the investigations that were done on presentation. You can see that he had a lower limit of normal MCV anemia. He had a neutrophilia. He was a little hyponatremic, and he was already showing signs of renal failure with a creatinine of 144. His albumin was 24. Interestingly enough, he had a normal LDH, but a quite high alkaline phosphatase of 393, and CRP was sky high. He also had a high uric acid and phosphorus that led his attending physicians to wonder about whether or not he might have a tumor lysis syndrome. His CT showed Anasarca and adenopathy, and an inguinal node biopsy, which was obtained, a complete surgical biopsy to the credit of Mount St. Joe's, was obtained almost immediately after admission, was a non-specific, and Dr. Lickley will discuss the pathology later, and he had an echo, which was unremarkable. And now I'm going to ask Jen Ellis to show the radiology. Just advance with it down here. Yeah.
Okay, so the first CT scan at St. Paul's showed a lot of the same features as was noted at Mount St. Joseph's. What we can see here, this is a coronal image on a CT scan without IV contrast. So it was a little limited on that basis, just because of his renal dysfunction, we did not give IV contrast. But what we can see is that there's fairly extensive free fluid around the abdomen, and we've measured the spleen there, and it's a 15.8 centimeters, so moderate splenomegaly. In his thorax, he's got at least moderate pleural effusions, and you can see pulmonary edema findings within the lungs. You can see some intralobular septal thickening and some patchy ground glass as well. What I'm pointing to there in the right axillary region are some mildly enlarged lymph nodes. And what was interesting about these lymph nodes is that they all maintained a fairly normal radiological appearance. So they had these normal fatty hyla and sort of an ovoid or coffee bean configuration. They weren't round and solid in appearance. So they were only mildly enlarged. You can also see one here in the right paratracheal region as well. Again, somewhat difficult to evaluate because of the lack of IV contrast. As you come down in the thorax, you can see a mild to moderate amount of pericardial fluid there anteriorly, and again, moderate to large pleural effusions. And again, just the arrows showing a fairly extensive amount of ascites. And the arrows here in the flanks, you can see extensive body wall edema and anasarca. So these inguinal lymph nodes, they're not huge, very mildly enlarged, and again, most of them demonstrate this fairly normal radiological appearance. On the right-hand image there, again, difficult without the contrast, but you can see just a bit too much soft tissue in the rich peritoneum, and again, some mild lymphadenopathy suspected there. With the contrast? No?
That's my own slide for the radiology, which I pulled off. So I want to actually extend a welcome to those people who are at other sites. We can't see you on the screen here, but we know you're there. We hope you're there. So in a very complicated patient, we try and do crystallization and a problem list. So I've provided you with his problem list, and in particular, Anasarca, which is a diagnosis I don't like to use too much because oftentimes people are called Anasarca. They've got a little edema, a little of this, a little of that. But he really had big league Anasarca everywhere you looked. And the lymphadenopathy, renal insufficiency, splenomegaly. And I wanted to highlight the alk-phos and the uric acid and phosphorus that led to a possible diagnosis of tumor lysis. So what do you guys think? Is there anybody that doesn't know the case that wants to suggest the potential diagnosis? And this is why large groups don't work well sometimes. Any hypotheses? So everybody has an approach to lymphadenopathy. Everybody has an approach to renal failure. Everybody has an approach to Anasarca. Maybe one way to do it would be to try and see by doing Venn diagramming and see what overlapped in those things. Okay, so I'll leave that then, and we'll leave that, and we'll talk about it later. So his creatinine actually worsened at Mount St. Joe's, and his phosphate and uric acid actually worsened. So is this tumor lysis? The criteria for tumor lysis, he met them with the uric acid and the phosphorus, but really you got to have tumor lysis, and usually it occurs with chemotherapy. So tumor lysis was a good thought, but maybe not. How about a cytokine release syndrome? So when I first laid eyes on him, I wondered if he had some capillary leak. His albumin's 24, but that's a hell of a lot of Anasarca for anyone with any albumin. And he didn't have increased portal pressures or any reason to think he had another reason for his massive ascites. So we wondered if a lot of this was due to a cytokine syndrome, such as IL-6, VEGF, etc. So chapter 2. He comes to St. Paul's after 8 days at Mount St. Joe's, and everything is negative. He's now been seen by 4 internists, a hematologist, nephrologist, and rheumatologist about to consult, and he's been seen by ID. A bone marrow is done, and we're waiting for the results to come back. So I do some Venn diagramming, and in today's world, all you have to do is type in your search criteria and see what pops up. So I used edema, renal failure, and lymphadenopathy, and I go on Scholar, and I also go on Google when I do my searches. And I got nothing really came up on Scholar, and nothing came up on the wide Google search. But you can see at the bottom, 2 cases of thrombocytopenia, Anasarca, fever. So actually, you'll see as this evolves that maybe you need to go down and start thinking, but he didn't have thrombocytopenia. So I'm there at day 2, I've spent 2 days thinking about this guy, and I'm worried about adenocarcinoma because his ALK phos is rising. He has no GGT. He's got a family history of cancer. He's got all these weird things. I really want to get a bone scan. And we actually fractionated his ALK phos. Keep looking for lymphoma, which I think everybody's thinking of, but you guys were all too shy to mention. And whatever it is, it's bad. And I'd emailed May Kazem, my senior. The Anasarca is certainly suggestive of a capillary leak syndrome, cytokine secreting source. Castleman can't be ruled out. And the reason was, as I was doing my Google searches, page 2, Castleman's kept coming up on all the searches, but didn't look like really good. So then I read up on Castleman in Google, in Wikipedia, which was the wrong place to read up about Castleman. And it's sort of, I was drawn to it, but then I just pushed it away. So chapter 2 continues. He gets sicker. His ALK phos climbs to 1,000 with a normal GGT. I want all you guys to start thinking about all the cases you've ever seen with a high ALK phos and a normal GGT that wasn't due to bone. His bone scan was normal, and he had normal, his isoenzymes were hepatobiliary. His creatinine climbed to 400. His Anasarca was unmanageable with diuretics, and he needed hemodialysis. So everything's going south with this guy. And he's got no diagnosis. His CT was unchanged, and all the blood work trickles in, nothing comes back. But now his platelets plummet, and every day they get worse, and they get to 13,000. HIT assay is negative, and IVIG is given. We're pretty sure this is a consumptive platelet problem, but there's no response to IVIG, and now he's needed to be daily platelet support. And he had a mildly leukoerythroblastic blood film at this time. So I'll draw your attention on the infectious workup to a couple of things. HHV8 negative, HIV negative, hepatitis serology negative, and all of the endocarditis organisms, etc., negative. Negative, negative, negative. Autoimmune, everything's negative except for IgE, which was elevated, and that's a misprint. It's 1592. They were 3 times normal. But absolutely negative autoimmune, and his marrow comes back, and it's got abnormal megakaryocytes and a little bit of increased fibrosis, but graded as 1 on a 4-point scale, I'd say. More granulocytic, but nothing in the marrow to tell us what's going on, and certainly you can't find any malignancy in the marrow. No M protein in the serum or the urine. His ascites was negative, and the left groin excisional biopsy was not diagnostic. So we are stuck with a guy who's getting sicker and sicker and sicker, and we don't have a diagnosis. We wondered about lymphoma, hematologic malignancy. I thought he really did have a cytokine storm, but I didn't know what was causing his cytokine storm. And then the other differentials were kind of less likely. And then Castleman's just kept coming up, and I just couldn't get around, I just couldn't figure my way through it. So on day 8, the R1 on hematology makes the diagnosis. Does anybody have any ideas? I gave a lot of hints. I kept talking about something. So the R1, Xenia Gukova, Googles and nails it with her Google search. So, we all get kind of stressed when our patients come in with all these Google searches. Do I have this? Do I have that? Why aren't you doing this? Why aren't you doing that? If you search lymphadenopathy, all you have to do is put Anasarca into your search instead of edema, and it pops up. Every single hit, all the top hits pop up with the diagnosis. And I had never searched Anasarca because I thought it might be too specific, so I always searched edema. But Anasarca is the key word here. Also, the patient had developed thrombocytopenia now, which was the key word. So if you search Anasarca and thrombocytopenia on Google, you get this thing, TAFRO. 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 The hell is TAFRO? You go on Google Scholar, TAFRO. TAFRO. What the hell is TAFRO? So, what the hell is TAFRO? How many of you who don't know this case have ever heard of TAFRO? That's a big zero. Nobody had heard of TAFRO, but it's TAFRO. So in 2010, and I'll show you why. In 2010, a Japanese pathologist internist presented 3 cases of lymphadenopathy with thrombocytopenia, anasarca, fever, reticular fibrosis of the marrow, or organomegaly. And you look back, and it's actually that kind of disease with effusions has been characterized for 30 years in the literature. But really, in the previous 6 years in Japan, a pathologist named Kojima had actually talked about a specific type of multicentric Castleman's disease that actually had specific pathology that was associated with the specific clinical syndrome of TAFRO. So we're talking about a clinical syndrome, TAFRO, and a pathological diagnosis, multicentric Castleman disease. So lesson learned. You got to look at this through different lenses. This is a whole talk that I do, but you've got to think of things by venning. You've got to look at what's the most marked abnormality or startling abnormality or unusual abnormality that has the smallest differential diagnosis that might be your key to unlocking the puzzle. There's a lot of different ways to get at diagnostic dilemmas, but now Google is the way to go for venting. So I learned that you have to do a number of different search terms. You have to go specific. You have to go vague. You have to redo your search. So if I'd redone the search with the thrombocytopenia, TAFRO would have popped up. And you have to do both Google Scholar and Google, clearly. And don't just stop at page 1. And if something pops up again and again, even if it's down on page 2, but it keeps popping up, like the Castlemans, you've got to explore it further. So those were the lessons I learned on Googling. So I was on the ward, and I was about to see the guy, and someone said, "Oh, did you hear about that he has TAFRO?" And I went, "What? I'm looking after him. What do you mean TAFRO? What's TAFRO?" And they said he has TAFRO. So I went to a computer on 7 Delta and just typed in thrombocytopenia anasarca and got that search, and I was like an epiphany. So immediately, and this is about the multidisciplinary collegial collaboration, immediately Heme, Renal, ID, and myself, all attendings, plus the house staff that were around, we got together in the 7-seat conference room, and Cam Bolt was Googling, and I think Bev was there, and Natasha Press, and Cam was in charge of Googling by the computer, and went through the case, and it was like, it's TAFRO, it's TAFRO. So we pulsed them and got an axillary node again to repeat. So what am I talking about? Well, I'm talking about Castleman's disease pathologically and TAFRO clinically. So Castleman is lymphadenopathy with specific lymph node pathology that's not malignant. And clinically, it can be asymptomatic, it can be unicentric, it can be multicentric, and it can have very, very clinical presentations. It's got a couple of other names that are more descriptive. But Castleman deserves his name. In 1954, at a CPC at Mass General, was the first case of Castleman disease ever presented in the literature. And I like to think that by doing this as a CPC, we're kind of paying homage to Castleman and also tying up the circle. In 56, by then he had gathered 13 patients, and I don't think he called it Castleman's disease. You don't really name diseases after yourself. Somebody else does it for you. And they showed follicular hyperplasia and capillary hyalization, which later became known as the hyalinization hyaline vascular variant. And later in the 60s, other variants were recognized with more with plasma cells, the PC variant, and we knew that it was unicentric and multicentric. And another variant of Castleman's is associated with poems. And we all, every medical student knows POEMS because it's got a cool acronym. But POEMS is another cytokine secreting syndrome, very similar to TAFRO as a clinical syndrome with a pathologic correlate. So what's all this story? So in the 90s, as most of you know, as all of you should know, Kaposi sarcoma in HIV positive, usually gay males, was linked to HHV8. And they started looking and seeing that a lot of Kaposi's and Castlemans happened in the same patient, so they looked at HHV8, and almost everyone who has Castleman's in HIV was HHV8 positive. And it's about 50-50 or a little less than 50-50 in HHV8, in HIV negative to be HHV8 positive. So if you look back, the Castleman that we know, because we're St. Paul's, we're an HIV center, the Castleman that we know, looking back, was an inflammatory disease. It was associated with the lymphadenopathy, but we did see a lot of Anasarca fusions, and it was very cytokine related. And then the HHV8 itself was linked as a pathological entity that causes IL-6 and VEGF secretions. So it kind of ties the whole circle of Castleman, HHV8, and cytokine storm. So back to TAFRO now. So TAFRO is a clinical manifestation of multicentric Castleman's disease. And so there's, like usual in medicine, when there's one case report, it just starts a flood and everybody looks back and goes, hey, I've got some patients. Hey, so if you go to the literature now and you Google TAFRO, there's thousands of articles and case series, consensus, etc. And then they started looking at the pathology of TAFRO in multicentric Castleman's, and they found that the people that tended to get the clinical syndrome of TAFRO had a distinct pathological appearance with atrophic germinal centers and increased vascularity, which was kind of very similar to Castleman's original patient. So now I'm trying to figure out how can I convince people he has TAFRO? So we go to the literature, and there's a clinical criteria published in 2015. And as you can see, he has all three major criteria of Anasarca, thrombocytopenia, and inflammation. He also had progressive renal insufficiency, mild splenomegaly, increased megakaryocytes on marrow, but I hadn't had any pathologist tell me as yet that he had Castleman-like features on node biopsy, and the nodes were going to the cancer agency and here and there. But in review with our pathologists, we certainly felt like it was a tenable diagnosis, and Lick will talk about this in a bit. And of course, you have to exclude all these other diseases. So what's noteworthy is hypergamma-globulanemia is rare. He didn't have it. No M protein, he didn't have it. LDH, he didn't have. The ALK-Phos he had in spades. And I really think ALK-Phos is a marker for this disease. And I'll show you more about that later. He had the mild splenomegaly, and the nodes were normal appearing and small. So like he fit TAFRO like a glove. It was like they wrote the book on him. But everything old is new again. So I was able to go back and find a 1985 paper of 15 Castleman disease patients that had been referred to as systemic Castleman's disease. And they were characterized by all of the things of TAFRO. So maybe this was the first big case series actually of TAFRO. I couldn't find out how many of them were actually thrombocytopenic, but half the patients had effusions and Anasarca. So nothing's new, right? You go back, nothing's new. So fast forward to the present, and this is kind of the classic article, which is a report of a consensus conference with 35 worldwide clinicians who brought their cases, and there were 244 cases, and they were all multicentric Castleman's disease in HHV8 negative patients. And so they call that idiopathic multicentric Castleman's because we know what causes the other kind. And they linked it to cytokine storm. So in the old days, we divided into HIV positive negative. Now we divide it into HHV8 HHV8 positive, in which case it can be HIV or non-HIV, or the HHV8 negative non-HIV, which is idiopathic. And if you look at this, and I'm sorry I don't have a pointer, but if you look at the right side, you can see that idiopathic multicentric Castlemans can have all the pathologies that we talked about. But TAFRO, which makes up more than half of idiopathic multicentric Castleman's clinical presentations, TAFRO has its own specific pathological appearance, which is more, which is less about plasma cells and more about hyaline and vascular and atrophic germinal centers. So the Castlemans that we know at St. Paul's because of our HHV8 HIV is not the Castlemans that we're talking about in this patient. It was very difficult to get through to people that this is not the Castleman. This is not your Castleman. This is Mr. SH's Castleman. So I went through the 2017 article, and we didn't have the node pathology. We had everything else. Everything else was in spades. And I guess, so the CRP, the anemia, thrombocytopenia, I'm not just going to read them. I'll let you read it off. But everything, he had everything. He had TAFRO. I bet you're waiting for the IL-6 levels, which we sent, which were 6 times normal. Solubilized IL-2 receptor, another marker of cytokine activation, was 4 times normal. VEGF was not abnormal, but it didn't bother me too much because VEGF is much more highly associated with old Castlemans, the Castlemans we used to know. His PET scan was normal, which really is against lymphoma. So we got a guy, he's got TAFRO, he possibly has a multicentric Castleman's disease. What am I going to do? I can't get any love from the pathologists to commit themselves. So Dr. Lee is going to present the pathology now.
Okay, so hi, my name is Kang Lee. I'm one of the pathologists here. And I'm presenting some of the pathologic findings for this case. So since we're going to show some pathology, I thought you guys should look at what a normal lymph node should look like, since maybe you haven't seen it since medical school. So this is the normal lymph node. So normally it's kind of, there's a specific architecture and organization to it. There's follicles that are more towards the edge in the cortex with increasing size of germinal centers towards the edge. And towards the center, there really aren't as many follicles. There's more vessels and then the medulla where all the vessels join up. So in terms of these Castleman features that we're talking about, so there's different histologies for Castleman. Actually, I'll show this picture first. So clinically, you classify Castlemans as unicentric, multicentric, and divide that into idiopathic and the HHV8 associated nowadays. Histologically, we don't know whether it's unicentric or multicentric. That just depends on what you see clinically. But what we classify is we classify it according to the various histologic appearance. And the classic histologic appearance that was originally described is called this hyaline vascular appearance, which some people have been calling hypervascular more recently. Then the other end of the spectrum is a plasmacytic or plasma cell rich type of Castleman's disease. And then there's a mix in between of the two different types. So if we go back to this picture, so there's this hypervascular type and then the plasmacytic type, and then mix is kind of a continuum in between. And from what I've read, the actual histology doesn't seem to be making specific clinical differences in treatment or anything, but there are associations, as I showed in the other picture, with different types of Castlemans. And some of the prominent features that are seen on the hypervascular end of the spectrum is having regressed germinal centers. There's this classic thing that we call like a lollipop germinal center, where there's a vessel that punctures right through the middle of the germinal center, a regressed germinal center. There's also follicular dendritic cells that are more prominent in these. All of the Castlemans appear to have increased vascularity and increased vessels in their cells. And then the plasmacytic type, though, is kind of the opposite. So instead of regressed germinal centers, they have hyperplastic germinal centers. And they have a lot of plasma cells, essentially, in the interfollicular areas, which is not seen in the hypervascular or hyaline vascular variant. So if we go back to here, so as you can see, the hyaline vascular variant is usually seen in unicentric, but unicentric can also see any of the other types as well. Idiopathic multicentric Castleman's disease has historically been said to be essentially mostly plasma cell or mixed types, with some rare associations with the hypervascular type. And the HHV8 associated multicentric seems to go into this other category, which is kind of almost a subset of the plasma cell called plasmablastic. There's more plasmablasts in there. So this is that diagram kind of sideways to show the continuum between them. However, this new TAFRO entity or old TAFRO entity actually seems to be focused more towards this hyaline vascular and hypervascular side of the spectrum. It usually does not present with this plasma cell rich or plasmacentric or plasmacytic spectrum. So, and TAFRO does fall into the idiopathic multicentric. So maybe some of these older literature which says sometimes it shows this, maybe those all belong to this TAFRO category. So anyways, this is one of the axillary lymph nodes that we received. So this is about 2 centimeters in size. Grossly, at low power, you can see that there's a bit, you don't really see those germinal centers. You don't see follicles forming towards the edge that prominently. So we say that this kind of has a bit of an effaced architecture. It's not really a normal nodes architecture. So we'll just zoom in here. So at higher power, or even higher power, you can see some of these germinal centers that are still there. So this is a very regressed germinal center. They're very small. Usually they can be much larger. Here you can actually see a vessel penetrating through it. So it's kind of like almost like a lollipop shape. And the mantle zone around the germinal center seems to be layering. It usually has a bit of a layered appearance, but this seems a bit more prominent. So we say that looks kind of onion skinning. The mantle zone is preserved or slightly increased compared to what we would normally say in comparison to the size of the follicle. One thing that we don't really see, though, is much hyalinization of these vessels. So there's this vessel, but there really isn't much hyalinization. Hyalinization just means there's like a bunch of pink amorphous material around it. So when we assess nodes, we usually do some immunohistochemistry in order to differentiate the different cell types that are in there. And CD20 is one of these stains. It stains for B cells. And germinal centers and follicles are made of the B lymphocytes, and the interfollicular areas usually have a lot more T lymphocytes. So this highlights how kind of atrophic all of these germinal centers and follicles are, and their kind of scattered architecture. So it's very reactive appearing in this picture. This also shows that there's areas where there are no follicles there, so they seem to have kind of expanded interfollicular areas. And this is just a higher power view of that same two follicles. So you can see the mantle cells, and the remnant of the germinal center is staining with CD20 because they are B cells. So CD138 highlights plasma cells. And although plasma cells, you can tell what it is on histology. And this just gives a nice picture of where these cells actually are. And this actually does not highlight much of a very significant increase or anything of these plasma cells. So the plasma cells are relatively within normal range. And this is some of the plasma cells as well. Now, I was talking about follicular dendritic cells. So CD21 is a marker that does highlight those cells. Usually these follicular dendritic cells are around the follicles and germinal centers. So sometimes we say it's kind of like a meshwork architecture that kind of looks like it holds the germinal centers together. And in this we see that, again, it follows that CD20 pattern. They're very small and atrophic. They would usually be much larger than this in a normal lymph node. And this is, again, highlighting it in higher powers. And sorry, these black splotches are actually anthracotic pigment just from the dirty air we breathe. There doesn't seem to be much of a follicular dendritic cell network expansion that in this node. So going back to low power node, just focusing on a different area, here we can see that there are all of these areas here, these kind of pinker areas, those are actually all of the high endothelial vessels in the node. And just going up closer, these vessels. So there is an increase in these vessels. There's quite a lot of these vessels proliferating in this interfollicular area. And that is one of the features of Castleman's as well. CD34 is a stain that highlights endothelium. So this just highlights how many vessels are actually in here. And of course, we did do an HHV8 stain as well, and that was negative. There was no HHV8 in this node. So essentially, most of the features that we see here, they're all kind of, although they're not super well developed, they are features that we do see in Castleman's disease, particularly the more hypervascular or hyaline vascular variant, which actually fits with a TAFRO diagnosis more than if we thought of idiopathic multicentric. In the past, we would have thought it should be plasmacytic instead. So the only feature that didn't seem to fit too well was the increase or expansion of follicular dendritic cell network. That's usually also seen in the TAFRO syndrome, but it wasn't really seen in this node. And this was just a little picture of the bone marrow biopsy. So it was called hypercellular, and there was increased and slightly atypical megakaryocytes as well. But there was no evidence of lymphoma or malignancy in there. And this is just a picture of the bone marrow, one of the cores, and at high power. These cells are megakaryocytes. As you know, they form the platelets. But there's all the various types of cells that are formed in the bone marrow, including the red blood cell precursors, such as these, and the white blood cell precursors. They're all here. And so it's a trilineage hematopoiesis, which is normal. It was just a bit hypercellular and a bit more megakaryocytes that were slightly atypical. They weren't really on the scale of severe atypia that would suggest a malignancy or anything, but this hypercellularity of megakaryocytes and slight atypia is described in the TAFRO syndrome as well.
Okay, thanks, Lick. So you can see the dilemma I was in. I was getting some buy-in from our pathologists that we might be dealing with a Castleman's node situation, but there was no hardcore proof, and the people at the cancer agency were coming up with all these different diagnoses that I had to draw their attention to the new literature on the classification of Castleman's, etc. So it was quite interesting. So he got his pulse, he got his node biopsy. Cancer agency said it might be Still's disease, got a room consult, got this, got that. Nothing changed. He continued to lose weight and deteriorate. So I can't get anybody to buy in that this is Castleman and treat it. But Heme says, well, maybe it is, maybe it isn't, maybe it's lymphoma. So he sort of compromised on cyclophosphamide, but he never got it. So I emailed to Kai, who came up with the syndrome, and his English was terrible, and he said, call Feigenbaum. So I emailed Feigenbaum, and I went away for 2 weeks. I was in Whistler, but I was calling and bugging hematology, everybody. I was following the case as if I was still the attending and calling and bugging everybody. And I was talking to and emailing Dr. David Feigenbaum at the University of Pennsylvania. Now, Dr. Feigenbaum has his own amazing story. He was a high-end college elite athlete, quarterback at the NCAA level, and he got sick with TAFRO clinically. He was diagnosed finally as having Castleman disease, and he's had a number of different therapies that he's actually argued for himself, and he's in remission, but he has relapsed in the past. And there's, if you can read about him on the net, and there's a picture of him as a quarterback running with the parachute behind you and ripped. And then there's a picture of him on the ward with gaunt with a belly like this. And so he and I became friends through this, and he was a tremendous support to me. The pulse steroid actually took care of his renal failure, but nothing else got better. Nobody was willing to pull the trigger. So I come back after 2 weeks, and he still hasn't been treated, but now there's some T-cell clonality on the marrow. So hematology wants to treat for lymphoma. And I go and I look, and it's a non-specific finding. It's not like what you want to hang your hat on for treatment, but lymphoma therapy is also therapy used for the treatment of Castleman. So I was all for it. And he got treated with chemo. And at the same time, I went to the cancer agency to get approved for an IL-6 antibody, an anti-IL-6 antibody called siltuximab, which is the only approved therapy in Canada. And he actually got approved for that. So he got first CHOP and then COP, which is more specific for Castleman, on February 14th. Drains came out. Creatinine was normal, ascites went away, platelets went up to 84 without support. And he went home in mid-March. He was getting stronger. And we debated, well, he's responded to chemo. Should we continue chemo, or should we switch to siltuximab now that we know? And they felt like siltuximab was a less toxic alternative, so he got switched to siltuximab for a couple of courses. And then let's see what happened with this.
So this was before chemo, so when he was still quite sick. And this was a contrast-enhanced CT scan. So basically showing the same stuff that we were looking at on the non-contrast-enhanced scan. And again, you're seeing some axillary lymph nodes there that are normal in appearance radiologically. You can see in that right axillary region, the post-biopsy hematoma, small one there. On the right, you can see again pericardial fluid, ascites, pleural fluid, and then extensive ascites, just massive amounts there. Again, you're seeing them a bit better now. You're seeing some lymph nodes in the retroperitoneum and splenomegaly. And this was an incidental sort of appearance of abnormal kidneys on this CT scan. These aren't enhancing. You have to take my word for it, as they should. They're quite hypoattenuating. You don't see good corticomedullary differentiation. And so you can see those there, that they're not enhancing appropriately. This was when he was quite severely, had a renal dysfunction. So this now is March after his chemo. And now you can see those axillary nodes, tiny. The mediastinal lymph nodes that were marginally enlarged, again, small. Our pleural effusions have decreased. There's still some pleural fluid. The ascites has decreased. You can see now that the kidneys are enhancing more appropriately as well. So here we have the spleen, March 14.5 centimeters, and looking back at the prior February 15.9 centimeters, so that's even decreased in size. You can see again on this coronal image that the fluid has decreased in March as compared to February. So another sort of incidental finding here, we look back to the January non-contrast enhanced CT scan. I've got arrows there, I'm not sure how well those project, but you can see some calcium in the adrenal glands now in March that he didn't have in January. So whether he had a bit of adrenal hemorrhage or something along the way, now we have some calcification in his adrenal glands.
So, feeling pretty good. This guy was like one foot in the grave, getting treated and doing much better. And feeling a little vindicated because he has Castleman's disease, he doesn't have lymphoma, right? Okay, do you want to present? So all this time, I'm trying to get the Castleman expert pathologist at Pennsylvania the slides so that they can confirm Castleman disease, and then they come back with their path report at the end of March.
Okay. Okay, so back to these lymph nodes. We get the report back from the University of Pennsylvania, and they draw our attention to something else in here. So if we again look at the lymph node, CD20 highlights the B cells, and CD3 highlights T cells. So I didn't show you this picture before. So there's T cells in all the interfollicular areas, which is normal. But if we look slightly closer at certain areas, for example here, usually there's nodules like that. We would think that they were follicles in germinal centers, so they should be CD20 positive. But there's actually nodules that are CD20 negative and CD3 positive, and CD3 being T cells. So these seem to be little nodules of T cells in here. And this is the H&E again. And if we look up at high power, quite a few of these cells are quite irregular looking. They have atypia that is not normally seen in these cells, although it's not really like at the level that we would say automatically anaplastic large T-cell lymphoma or something like that. However, some additional stains were done, although these were also done by the BC Cancer Agency, which highlights that these cells have a subset of the population that we're staining with CD30, which is frequently positive in several types of lymphomas, including anaplastic large cell lymphomas and Hodgkin lymphomas, and CD25, which is also positive in various types of lymphomas, although they do highlight certain reactive lymphocytes as well. And because of that, an ALK stain was also ordered to try to rule out an anaplastic large cell lymphoma, and that was negative. So there were, molecular was done on this node, and the T cell clonality was negative, although if a node, it really depends on how the node was cut. If it was just partial involvement of the node and you don't happen to get that area, or it's too little of it, then you wouldn't see the clonality. So there were different reports that came from different places. So the BC Cancer Agency did call this an atypical lymphoid hyperplasia, but then they said that they favor that this is overall a reactive process. However, this is the University of Pennsylvania report, and they actually called it a partial involvement by a peripheral T-cell lymphoma. So they said that in summary, while there are features reminiscent of Castleman's, there's partial involvement by an atypical infiltrate that is suspicious for peripheral T-cell lymphoma that may support the presence of ALCL or T-cell lymphoma NOS. And Dr. Megan Lim, who did this, said, if there's a T-cell lymphoma in a node, then you don't call it Castleman's disease, even if it looks like Castleman's disease.
Oh my God. Oh my God, what do I do? Thank God he's under hematology now, not internal medicine. He does have a T-cell lymphoma? Well, does he or doesn't he? He's got about as much chance of having a T-cell lymphoma as he has of Castleman disease based on the differing pathologists. But he clinically has TAFRO. So, and his other nodes are Castleman-like, but you can't call it. So back to the literature. Google Scholar, Castleman and T-cell lymphoma, really no love. Google, Castleman and T-cell lymphoma, really no love. But all I could pick out from my literature review was this 2002 case series of 8 people, and the review of the literature came up with 42 people with Castleman's and either non-Hodgkin's or Hodgkin's disease. And there were only 6 cases before 2002 of these 2 entities occurring at the same time. And of course, if you do occur, you've got the bad prognosis from both. So it's the terrible prognosis. So if he does have T-cell lymphoma and Castleman's, bad prognosis. And it suggests some kind of signaling process, because when they found Hodgkin's disease in that area, that's where they found the Castleman disease. So it suggests that there's some local signaling process going on. And this is just the cartoon lifted from an article, which is, what happens is the HHV8 virus, the virally driven hypothesis, directly secretes cytokines, and the release of cytokines stimulates more cytokine release that stimulates lymph node tissue to proliferate, that stimulates more cytokine release. So it's like the vicious cycle of cytokines, which can be just initiated by a virus. But there's also a theory that some kind of abnormality in the lymph node can initiate this and turn on the cytokines and give the cytokine syndrome and turn the nodes into Castleman-like nodes. And no one really knows. So it's a very, very interesting hypothesis that this man had T-cell lymphoma, even at a tiny little part of his node, and that was enough to signal cytokine storm in him and turn on his other nodes to turn into Castleman-like nodes, and everything begets everything. So it makes sense that perhaps chemotherapy was a good idea in the first place. And unfortunately, he relapsed after his 2 courses of cetuximab. So what would you do now? Well, he got better on chemo. He didn't respond to cetuximab, which is only a 60% response rate anyway. So he's back on chemo, and I think I'm going to skip these are all the bad news radiology from his syndrome coming back. So to summarize his course, with the platelet count, he came in, he maintained normal platelets for about a week, then he plummeted his platelets. That bump is where he's getting platelet support, and then the rise in March is from his chemo. Similarly, his creatinine, it peaks, he gets steroids, and his creatinine comes down and normalizes. And his alk phos, which peaked at 1,000, came down around 300. So I believe the alk phos is a tremendous marker for TAFRO syndrome, actually. And now you can see as he relapses, now his platelets are giving him problems again, and he's relapsed with a rise in his alk phos. So in summary, bad disease, difficult diagnosis, Hickam and Ockham. Is it a patient can have as many diagnoses as he damn well pleases? Does he have T-cell lymphoma and Castleman? Or Ockham, where they're both related? I think they're both interrelated. Don't anchor. I was sure he had TAFRO, but now he has lymphoma. They were sure he had lymphoma, but then he had Castleman's. And so you have to be open to everything all the time. And when you're doing your diagnostic reviews, you got to keep looking back. If you don't have the answer, every new piece of information has to be filtered in the same way that you filtered in the previous information, with an open mind and trying to avoid all the 50 cognitive biases that will interfere with your differential diagnosis. And the last point I want to talk about is get help. We had multidisciplinary cancer agency, St. Paul's, University of Pennsylvania, even one email from Japan. So the important thing and get the best help, right? So I want to acknowledge Xenia, who made the Google diagnosis with the flying fingers on Google, Vesna, who presented this case at Morning Report, and I lifted some of her slides. My senior residents, Dr. Ramadan, who assumed care, lymphoma group, and my co-speakers, and especially Dr. Fagenbaum, my good buddy now in Pennsylvania. So thanks a lot. I'm sorry we went a couple minutes longer than I expected, but I do have time for questions if anybody has any questions.
interesting case. Thank you. I'm just wondering, with the elevated uric acid level...
Code blue, Providence 5 Charlie, CSSU. Code blue, Providence 5 Charlie, CSSU. Code blue, Providence 5 Charlie, CSSU.
You can always tell how many people from ICU are here at rounds when the code blues come off.
With the elevated uric acid level, it makes you think of the spontaneous tumor lysis syndrome. Would that be ever described in Castleman?
I don't know if it's been described in Castleman's. I don't think he had that much tumor to have tumor lysis, really. His nodes were small, you know, and he didn't have the prodrome for tumor lysis syndrome, but he was treated for it twice, actually. Well, that's a good question, and that is going to be the thrust when we present this as a case report. Before I knew it was T-cell lymphoma coexisting with Castleman, like, what does the world need? Another case report and review the literature on TAFRO when there's, you know, they're everywhere. So the thrust of our case report that we were going to do was to actually look more carefully into the ALK phos, and the answer is I don't know. I've never seen, in the literature, I could not find another syndrome that had hepatobiliary alkaline phosphatase without a GGT. So I think this is some weird cytokine release thing, and it may turn out to be a very useful marker, and that could be our contribution from this case to the world literature on it. Is there anybody out there? Are they out there?
No, but they usually will text the questions, but I haven't.
Okay. All right, then. Any more questions? Thank you. Do you have
no, I don't.
Like air, whatever it's called? Well, it's going to be like 40 megabytes with. The problem was, I need your slides, obviously. Still a pretty modest show. No hematology stuff, but I know. And a meeting. So I couldn't, if they were here,
Or probably whether they were right.
Well, no, everybody's right.
I guess so.
Everybody's right. Your patient
they were right to treat him with chemo for sure, because but they based their diagnosis on something that didn't exist yet.
Yeah.
But they were right. Chemo was the way to go.
She saw very pleasure and our guys who paint it's not from not in a pump.
I think the problem is that there's a difference.
The time was uncomfortable.
None of them took the time to educate themselves to the degree that they needed to be the attending physician, except for Khaled. But it took him a long time too.
But in a way, it's a fresh pair of eyes every time. It's a fresh pair of eyes every week. Which is
Fresh pair of eyes is nice, but when you got a rare disease, then how are you gonna, like, every single person has to learn about that? You know, you're the consultant. It's your job and your responsibility to learn as much as you can about the disease, and they weren't informing themselves, right? Except finally, you know, Khaled was the one who finally informed himself, but it even took him.
Until the next time he was on?
No, he was treating for T-cell lymphoma because of the bone marrow clonality, and then I was sending him articles and stuff, and I wasn't getting feedback as if he'd been reading the articles, and then he finally clued in, and then it became Castleman Disease, and then he was fine with it.
So
Where'd my food go? Business too quick.
do you want me to continue?
So but I think we have to figure out why we're going to write this up.
Yeah.
If we're going to write it up about the T-cell stuff, and the thrust will be the signaling and everything like that, or we're going to write it up about the alk-phos, because otherwise those are the two great things about the case. Fagenbaum still hasn't run those 7 vials of blood that I sent him 4 months ago.
What did you send that for?
Sent him 7 vials of blood.
No, it's do your test.
I have no idea. So that may give us a clue. So I think you've got it to the point where it needs to be, but I think we need to know what the thrust of our presentation is going to be. Now, if you just want to present it as I think you should, at the Canadian Society of Internal Medicine, the Osler competition is a case report, and you get a catchy title, and you've got a weird diagnosis. You're gonna you'll get accepted for oral presentation, or you'll do a poster, and I think you should focus on that for now. Their deadline is sometime in the next. I don't know when the deadline is actually. I'll have to look it up. I'll find out for you the deadline. Remind me if you don't hear from me in a day or so. And then you just have to do an abstract, right?
Yeah, I'm looking it up right now.
Yeah. Osler competition, CSIM.
Thank you for doing rounds. Jake, you're always a pleasure to listen to. I like the case as well.
Yeah, I think too many rounds are
just so boring with the slides. And this is fabulous. This is real life. This is the creme de la creme of interesting stuff that rolls through our unit.
Unfortunately, I think he's going to die. But.
Yeah.
He's here now? He's here now? So his chart is going to be now.
It's going to turn the mic on.
June 27. June 27.
June 27. Okay. It should be pretty easy. I'll help you get it down to whatever the rules are and how many words and everything.
Okay. Cool. Sounds good.
All right. You'll have to bring. Do you have an app? Do you have a Mac? Oh, yeah. From Keynote?
From
Yeah, well, he relapsed and then. I don't know how.
You should have said him under you.
No, he's seeing patients. So if I'm saving that PDF, the response.
So this is the problem.
Your call will be disconnected.